Hello, and welcome back to the Oncology Brothers podcast. I'm Rohit Gosain, and as always, I'm here with my brother and co-host, Rahul Gosain. We will continue with our treatment algorithm series focusing on breast cancer. We have recently covered triple-negative breast cancer with Dr. Virginia Kaklamani, and today we'll dive into HER2-positive space. For this, we are excited to have Dr. Sarah Sammons from Dana-Farber Cancer Institute. Sarah, it was great to finally meet you in person at SABCS 2024. Thanks for joining us today.
Happy to be here.
Welcome. So to get us started, let's focus on the treatment paradigm for HER2 positive early stage breast cancer, where the tumor is less than 2 centimeters and is indeed node negative. We, of course, have mature data from APT trial with Taxol and trastuzumab, efforts led by your team at Dana-Farber. In your practice, are you strict about treatment only with 5 millimeters and above disease? Anyone that you would consider neoadjuvant treatment in these settings? What are you doing when it comes to early stage HER2 positive disease?
Great question. It's always easy when disease follows the algorithm specifically, but where it gets tricky is those gray area cases. And I think those are probably what makes up about 50% of our weekly tumor boards, right? Gray area cases in early stage HER2 positive breast cancer. What are we doing with those T1A tumors? So those tumors that are less than 5 millimeters. I would say that my practice generally depends. When it's less than 5 millimeters, you really have to think about the patient. What's the age of the patient? Are they young? What's the estrogen receptor status? So we know that estrogen receptor negative HER2 positive breast cancers have slightly higher relapse rates without any therapy alone than the ER positive, HER2 positive ones. So it's really case by case, but I would say in my practice for less than 5 millimeters, I'm more likely to treat with something like Taxol Herceptin if they're estrogen receptor negative, if the patient is young, if there's multiple foci, I'd be more likely to treat. And it's also a discussion with the patient, right? So we go to some of the retrospective series that we have, and then based on them, you can say something like, with no therapy, your risk of recurrence is maybe 7%, where it's 1% with therapy. And then you let the patient decide. That's kind of my thoughts on small tumors. What is that kind of mirror what you guys are doing in practice?
Yeah, and that conversation is very similar. Actually, just today in clinic, this patient was triple positive, though. The tumor is 6 millimeters, and you're going back and forth saying, this is ER positive, this is HER2 positive. What do you do? But in this case, for me, it was grade 3, high Ki-67. So we're moving forward with the whole shebang. But then let's take another extreme where in Keynote 522 for triple negative breast cancer, what we tend to do is even for 1.5 to 2 centimeter, at times bring up this neoadjuvant idea. But we have very good data with APT here. Is there any patient that you consider neoadjuvant treatment if it's less than 2 centimeters, Sarah?
Yeah, this is tricky too. And this is a gray area. What I'm always trying to determine is, am I getting the size right? Because no matter what we do, we fear undertreatment, but we also fear overtreatment. It's hard to get it just right. For a T1C, if I'm on the fence, I always think more imaging is helpful. For a T1C, we're definitely always doing an axillary ultrasound, making sure that there's no abnormally plump lymph nodes, which would tip us over doing neoadjuvant treatment per standard of care. So for a T1C especially, making sure I get an axillary ultrasound, making sure there's not an abnormal node. Where I think it gets tricky, less than 15 millimeters, negative axillary ultrasound, I'm happy to send them to surgery. We have such good data with TH. You're not going to get much better than a breast cancer specific survival with something more than TH, right?
Absolutely.
But if it's really getting close to the 2 centimeter mark, what does it look like? Is it estrogen receptor negative? Is it grade 3? Is it a young patient? Is it a patient where we have a good chance that we're going to take them to surgery and then it's going to tip over that 2 centimeter mark? There have been situations for HER2 positive cancers that are very close to 2 centimeters where I have offered neoadjuvant Taxol, trastuzumab, pertuzumab, so that I can get that data on, pathologic complete response. And then I can either escalate their therapy if they don't have a PCR to TDM1, or de-escalate at Herceptin if they do have a PCR. Now, it's tricky because that's not necessarily in the NCCN guidelines yet. There is a phase 3 clinical trial that's ongoing called Compass PCR that is looking at 4 cycles of Taxol, trastuzumab, pertuzumab. And so that will at least be a little bit helpful on what to do for these larger T1Cs.
Thanks for going over that, Sarah. And as you stated, a lot of the patients that we see are in this gray zone. Now, diving into locally advanced disease, where tumor is larger here, and there is, in fact, nodal involvement. Here, TCHP has been the standard of care in neoadjuvant settings. Yes, we've seen PAT-CR rate, which are better, but of course, it comes with increased toxicity. Sarah, your treatment paradigm here?
Yeah, so I think in the US, we've definitely moved towards a locally advanced or stage 2 or stage 3, which is the cutoff of 2 centimeters or greater and node positives. You want to give them neoadjuvant treatment because the reason for neoadjuvant treatment is to assess the response and to escalate or de-escalate therapy based on that, which, the opportunity for adjuvant TDM1 is probably one of the most notable interventions we've done in the last decade, reducing the risk of distant disease and improving overall survival. So that's something that you really don't want to miss in these patients. Now, we have studies that have looked at anthracycline, taxane, HP versus TCHP. And while TCHP was very slightly inferior, it was almost the same. And it certainly had less long-term bad side effects than the anthracycline, Cytoxan, taxane HP regimen, which had a higher risk of heart failure and a higher risk of leukemia. And so for the vast majority of patients, I am going to use TCHP. I have used ACTHP in some patients. I can think of 2 cases this year where the patient had a HER2 positive primary tumor, but their lymph node was HER2 negative. Or there were 2 tumors, one was HER2 positive and one was HER2 negative. And you wanted to sort of give a regimen that was going to effectively treat the heterogeneity of a hormone receptor positive, HER2 positive, and HER2 negative tumor. That is when I have actually in the past used the ACTHP regimen. But for the vast majority of patients, I think we're going to go forward with TCHP.
At SABCS, they actually did a survey saying how many people are using anthracyclines in HER2 positive disease, no other caveat. And about 30-40% of the crowd raised their hands. This is what's available outside the US. In my practice, I have not used anthracycline much in this patient population. We have anti-HER2 therapy, dual anti-HER2 therapy. We have to keep side effects in mind. Even with TCHP, we have to keep diarrhea with pertuzumab in mind, neuropathy that comes along with Taxol, marrow suppression with carboplatin, of course, the cardiotoxicity with any anti-HER2 agents. Sarah, any clinical pearls around managing toxicities with this regimen?
Yeah, I think the TCHP regimen is really tough. And I warn my patients about that. I think it's a pretty challenging regimen to get through. I think it's important to tell them at the first sign of diarrhea to start taking Imodium because there's a lot of diarrhea with this regimen. Just counseling them that if they're still, despite Imodium, having diarrhea, give us a call. We'll prescribe Lamodal. If you're not keeping up with fluid intake, give us a call, come in for some IV fluids. It's not an easy regimen. About a third of my patients on TCHP, I end up de-escalating to just THP. I haven't looked at that statistically, but I can just think of this year alone, 3 or 4 patients who I tried dose reducing once, I tried dose reducing again. They were still miserable. And then I ended up flipping them to weekly Taxol HP. And I would say I have to do that a quarter to a third of the time in my practice. And so I will do that if it's necessary. I think dose reductions can be incredibly helpful. I think just really counseling them on managing the diarrhea, managing the dehydration, bringing them into the clinic early to check electrolytes, give fluids if needed, dose reducing, and then sort of last case scenario, if you can't get them through it despite a dose reduction or 2, flipping them over to THP, I have done.
Okay, so after neoadjuvant treatment, if we have residual disease, we touched on this briefly, we can consider escalating to TDM1. And this happens in about 30 to 40% of our patients. We now have mature data for KATHERINE trial, which is amazing because of the overall survival benefit. Sarah, every now and then, this residual disease is indeed microscopic. Are you still reaching out for TDM1 in that scenario, or do you feel comfortable with ongoing dual anti-HER2 therapy?
If you look at the KATHERINE data, it didn't matter what amount of residual disease the patient had. There was a benefit to doing TDM1. And so really for any residual disease at all, I am offering TDM1. Now, of course, if there's poor tolerance to TDM1 or they're developing worsening neuropathy because of the TDM1, I think for someone with RCB1 disease, you would be more likely to stop early and then finish with the Herceptin with or without Perjeta. For any degree of residual disease, I am offering it. I also think it's really important, it's not mentioned here, but I think we're learning more and more that in hormone receptor positive, HER2 positive patients, optimizing endocrine therapy is very important as well. So in the residual disease and the PCR patients that are hormone receptor positive, I am still strongly recommending endocrine therapy.
Right, we're going to bug you with PATINA trial when we talk about the metastatic population, but yes, that is my approach as well, and I'm sure, Rahul, that's your approach as well with the endocrine therapy in adjuvant setting. And the other hesitation always is when to reinitiate HP or TDM1 at the time of radiation, after radiation here.
Yeah, it's a good question. I think I tend to initiate it when they come back. And through radiation, we have very good safety data to give radiation through trastuzumab, pertuzumab. And actually in KATHERINE, radiation was allowed while patients were on TDM1 as well. So I find that my patients just want to get through the rest of this and keep moving forward. And so I tend to continue it through radiation.
Okay, I know we've talked some about this triple positive patient population. Sarah, is this where you lean towards neratinib? Are you using neratinib? Who gets neratinib in your clinic, if at all?
I really have not used neratinib in the early stage setting very much. We don't have data in patients that have had pertuzumab and TDM1 and how that would impact treatment. The highest risk patients that are estrogen receptor positive and HER2 positive, had residual N2, maybe N3 disease, and you're just very worried about the risk of relapse. I think it's reasonable after a year of HP or TDM1, but we just don't have the right data for its use nowadays, and its side effects are not easy.
Absolutely. As Dr. Graf would say, I consider this for someone who's stage 3.95, as close as it gets to stage 4, and maybe bring this up. Okay, now switching gears to metastatic disease. Sarah, the current standard of care here is chemo with dual anti-HER2 therapy and then maintenance dual anti-HER2 treatment. This is currently being challenged by T-DXd in frontline, but right now, outside clinical trials, your treatment paradigm for metastatic disease.
Absolutely. So Cleopatra is still king in the first line setting. And about 20% of our patients are going to be long-term responders with this strategy, meaning that they're going to be on it for more than 3 years, some of them more than 10. So what would be nice is to tease out who those long-term responders are. Some studies have shown that you're more likely to be a long-term responder with THP if you have ER-negative disease, you're HER2 3+, and you don't have lung or liver mets. Unless you've relapsed within 12 months of your adjuvant therapy, I think that THP is standard. And so I generally give 6 to 8 cycles of the taxane. As long as they've had a response, you take off the taxane and continue the trastuzumab, pertuzumab. Now, we saw an amazing study presented this year at San Antonio by Dr. Otto Mesker called the PATINA trial. And it was patients with estrogen positive, HER2 positive disease who had non-progressive disease, so either a CR, a PR, or stable disease after 6 to 8 cycles of their taxane HP. And then they were going on to their HP maintenance, and one arm got HP maintenance with aromatase inhibitor, one-arm gut HP maintenance with aromatase inhibitor and palbociclib. And we saw the longest progression-free survival in the metastatic setting that I've ever seen in breast cancer of 44 months with the addition of palbociclib versus 29 months with just HPAI. And so really almost a 4-year PFS. This is after 6 months of induction. This to me is practice changing. It's technically not FDA approved yet, but I am offering it to the right patient already. I hope that it will be FDA approved soon so that we can more broadly offer it to our patients because, AI, palbociclib, there's side effects, but we've been using palbociclib for almost a decade now. We're very familiar with its use and how to manage it. It's a chemotherapy-free regimen with a PFS of almost 4 years. I think that's practice changing. I'm excited for the FDA approval.
Right. I think I've not utilized it since SABCS, but I'm definitely waiting on a patient to utilize because this is in fact practice changing, especially profound PFS, as you stated, close to 4 years. That is unheard of, especially when you're talking about stage 4 setting. Now, moving along into the second line space, data from Destiny Breast 12 looks very promising when it comes to intracranial activity with T-DXd. And then we also have tucatinib-based regimen, which is a triplet regimen, and which also has great intracranial activity. Sarah, your preferred regimen here if a patient is presenting with brain mets?
It's a good question. I think for the vast majority of second-line patients, we're going to use T-DXd. It has an incredible progression-free survival. The caveat to Destiny Breast 03 and the other Destiny trials is that they did not include an active brain metastasis population, meaning either untreated or treated but progressive with radiation. That's where Destiny Breast 12 came in, where they really looked at its activity in the active brain mets population. Before then, we only had these small studies, which looked very promising, but this was sort of the first large phase 3 perspective. And what we saw from Destiny Breast 12 is that T-DXd has excellent intracranial and extracranial activity in active and stable brain mets patients. And so I can't really tease out a second-line population at this point that I'm not just choosing T-DXd. Now, I have had an occasional patient that really doesn't want to go on IV therapy again, wants a regimen that's oral, that is not just sort of ready to tackle IV therapy. And for that patient with brain metastasis in the second line, I think that the HER2 climb regimen is reasonable. But for most patients, I'm using T-DXd in the second line and then HER2 climb in the third line.
Certainly, that has been my practice as well, unless there is a true contraindication to T-DXd, or as you said, the patient preference is for capecitabine or tucatinib-based regimen. The plan is definitely T-DXd, though important to keep the side effect profile in mind, especially with T-DXd, with ILD alopecia, with ILD death associated, as we have seen with the trial itself, though we are getting more educated on that aspect, following these patients closely, where that has rather minimized. With regards to diarrhea, which is an issue with pertuzumab and also a concern with tucatinib and capecitabine-based regimen. Now, thereafter, after exhausting T-DXd and tucatinib-based regimen, now we are in data-free zone. Sarah, how do you tackle this and how do you sequence the approach here?
I think it's really tough. We are in a data-free zone. I think that TDM1 definitely can still have efficacy here in terms of we're really limited to real world data series from Flatiron, post TDXd and things like that. I still think that TDM1 is very reasonable in the fourth line after TDXd and HER2 climb. So definitely an option. I'm also think that in the right patient, doing some sort of chemotherapy with either trastuzumab or margetuximab is very reasonable. I like eribulin. I like navalbine. I like potentially carboplatin with either trastuzumab or margetuximab. The margetuximab data is not super impressive in my opinion, but for the right patient, we are testing sort of the FC region that in the clinical trial that, patients had to not have a specific biomarker. And as long as they didn't have it, margetuximab was a little bit better than trastuzumab. So we are testing that in the clinic. But I think margetuximab with chemo is reasonable. I think trastuzumab with chemo is reasonable. I like eribulin, carboplatin, or navalbine as some of my potential options. There's gemcitabine as well.
Coming back to margetuximab, the reason why we're all not thrilled because there was no OS, but in my practice, I have combined this with gemcitabine and saw some disease control in a young patient. When it comes to fourth, fifth line, we're all reaching out to anything that's available as long as our patients are tolerating this well. And coming back to T-DXd, tucatinib, you both touched on PATINA trial. Our patients are living longer and longer because of these advances. Actually, when I'm bringing up PATINA trial, another thing to mention is this was with palbociclib. Combining or leaning to abema or ribociclib while we're using Herceptin or Perjeta is not recommended, be it because of the diarrhea or cardiac toxicity. So for our listeners, if you're going to lean into PATINA, we'll likely stick with what was done in the study, which was palbociclib endocrine therapy with ongoing Herceptin and pertuzumab. Sarah, we've covered a lot here. Thank you for sharing your insights and clinical pearls when it comes to treating HER2 positive breast cancer. For our listeners, let us go over some key points from today's discussion. In today's discussion with Dr. Sarah Sammons from Dana-Farber Cancer Center, our focus was on HER2 positive breast cancer. Rohit, when it comes to early disease, I'm going to continue to rely on surgery and then Taxol and trastuzumab in adjuvant settings based off APT trial. When it comes to locally advanced disease, TCHP remains our current standard of care in neoadjuvant settings, but managing side effects with this combination is important. Rohit, what are your key takeaways in metastatic settings?
Rahul, one more thing to add, at least for my practice in community settings in the US, is rare use of anthracyclines, as we have good dual anti-HER2 options here. Okay, now focusing on metastatic settings, I'm eagerly awaiting on T-DXd data in frontline setting, but Taxol with trastuzumab and pertuzumab still remains the standard of care treatment as of today. From SABCS 2024 PATINA trial, where use of CDK4/6 inhibitors and endocrine therapy after initial induction chemotherapy and ongoing anti-HER2 therapy for triple positive patient is now going to be my go-to regimen.
Yeah.
We do have few options in second line and third line settings, but Rahul, as you had mentioned, with each treatment option, we also have to keep quality of life at the center of all this. Thanks for tuning in. Make sure to check out our other treatment algorithm discussions. We are the Oncology Brothers.